Hi, I'm Dr. Corey Waller, and today we're going to talk about really the Addiction Neuroscience 101 within the Justice Involved system. And we have a few objectives we would like to get to with this, and we'll start with really trying to focus on understanding where we are in the world of addiction as far as it pertains to the Justice Involved population. You know, people in jails, people in prisons, those in pre-diversion programs, as well as those in parole and probation, kind of what we understand about their risks and the interventions that we might be able to have with them. The other is I really want to make sure that we can explain how addiction affects the brain at a relatively deep level, because I think that the more that you understand how addiction affects the brain, the more likely it is that you're going to really feel comfortable at understanding the behaviors associated with addiction. We're going to follow this by talking through some of the medications that we can utilize to improve outcomes in addiction, and that includes things like opioid use disorder, alcohol use disorder, tobacco use disorder, and the like. And by the end, my hope is that you'll really understand the reasons behind needing medications in order to be productive in the delivery of things like psychoeducation and psychotherapy. If we start with the density of this problem right now in the United States, it's pretty bleak. I first gave this lecture back in 2016, and I remember looking at the numbers and the stats at that point, and they sat around 40,000 overdose deaths per year. Now, 40,000 overdose deaths per year is massive, and at that time seemed overwhelmingly large. However, in 2021, as seen here, we were over 100,000 overdose deaths. And in 2022, it's looking to be the same by the end. So this problem has consistently gotten worse, and it looks like it's not going to turn the curve unless we do some really important work. And if we're going to get started on what is the biggest improvement we can make, I would ask that we kind of fall back on this concept called the Pareto Curve. And this means that what are the populations and what are the interventions that we can do that have the least amount of work associated with them with the biggest amount of impact, so that we can rapidly try to turn the tide. Now, luckily, if you're watching this video, you're probably involved with the population that is most important for us to intervene upon rapidly in order to make these big changes. So in the justice-involved population and those in jails and prisons, right now, this population is about 2.1 to 2.3 million people large. About 1.5 million of those suffer from a substance use disorder. And then if we add on other ones, another 500,000 people who had either alcohol, drugs in their system when they committed the crime, or were arrested for things associated with a drug violation or an alcohol violation for that. Now, if we just look at the prison population, you add these two populations together, and that's about 85% of that total prison population. And there's no reason to think it's not the same within jails. And quite honestly, those on probation and then those diversion programs, it's probably even higher. So when we look at a population that we can rapidly and consistently intervene with, this is definitely one. 85% of a population has a disease that we have evidence-based ways to screen, to assess, to treat, and then we show really good positive outcomes long-term. So this really fits that definition of the Pareto curve that I was talking about. But if we dig into this population even a little more, we find that if we look at those that are re-entering from prison and jails, we find that 38.3% of that population has both an illicit drug and alcohol use disorder. We have 24.9% of those that have an alcohol use disorder by itself, and then 19.7% with illicit drug disorder. So that means methamphetamine, opioids, benzos, all of these things. This is how we break out the approach to this population. And so recognizing that the re-entry population has a high density of disease burden lets us know that as we treat them inside of jails and prisons, we really need to prep the world for them as they re-enter with our probation and parole colleagues, and then out into the community. If we look at recidivism and the impact a little deeper, what we find is that a study that looked at 15 states found that a quarter of those people who had been released returned within 3 years because of a positive drug test or a drug use that put them into a situation where they had to get violated back into the system. So this is problematic. And the scariest part is that after post-release, we find that those with an opioid use disorder are 40 times more likely to overdose within the first 2 weeks released from prison. 40 times. That's not 40%. That is 40 times more. And if we look at the group that has a heroin use disorder and the injection use disorder, they're 74 times more likely to do this within the next 2 weeks after release. These are unfathomable numbers, and this is when you compare them to people in the community who have the same disease. So when we start to look at the risks, these aren't short term. So these look at the first 2 weeks where it's huge, but even if we look out a year later, what we identify is that we still have a 10 to 18 times higher increase in risk of overdose as compared to a population not involved in the justice system. This shouldn't stand. This doesn't make sense at this point in time for us to know that we have a population that has high density of disease, we have good treatments, and we know that they die at an unfathomably higher rate than those that correspond with the same disease in the community. If we look at the laundry list of things that people die from after re-entry, we can look at a lot of things. But what I want to draw attention to is the number one thing on this list is overdose. Overdose is the number one risk of death for those in re-entry. So it's not only a big risk, it's the risk. And so as we start to think about the systems we have to build and why we need to build them and the interventions we should be, making a normal part of daily treatment, we really have to go back and look and decide, are these the problems that we need to solve? And the answer is yes. So as we move into this next phase, I want us to understand the disease of addiction to the point of we recognize not only is this bad, but we know why it's bad. We know how they got this. We know why it developed into the behaviors that we see. And then from that, we should be able to lead into understanding why treatments like medication-assisted treatment help in this population. So if we start with, we need 3 things to survive, right? You need food, you need water, you need dopamine. Now, my sciencey friends are going to come back and tell me that, yeah, we need oxygen. Well, we need skin too. But today we're going to focus on food, water, and dopamine. And dopamine in particular, because dopamine is this chemical in the brain that is responsible for, helping us to feel a reward. It's in this reward system. And I'm going to be specific about the places in the brain that this is released because I think it's important for us to truly understand that so that we can convey this message and understand it ourselves. So dopamine is so important that it is the main player in all of our motivation. And so if you say, I'm motivated, what you're really saying is, I have enough dopamine in my brain to go do this thing. If you're saying, I'm not motivated, then what you're saying is, my dopamine level is low. And so throughout the rest of this interaction, I want you to think about motivation if I say dopamine. And if I say dopamine, I want you to think about motivation. And so if we really walk through the process, you cannot have dopamine release without creation of motivation. And you cannot have motivation unless your brain has squirted out some dopamine. So it is important for the movement through the world that we have, the way in which we excel. So if I'm at work and I do a good job and I get patted on the back, I get release of dopamine, I'm motivated to do that again. If I'm up to the plate and I hit a double and it feels great and I want to go back and it tells me, man, that felt great, I want to do some more for that, then it motivates you to do more training and more practice till you get to that point so you can feel that again. In fact, it's so important that science has really focused on the understanding and development of this dopamine model to really understand exactly how much dopamine we need. And if we break it into a construct of, let's say, 50 nanograms per deciliter, this is the amount that we would need on a daily basis to just get out of bed, get out of bed, get the first cup of coffee, go to work and have a full day. That's the normal thing. You wake up and we're good. Bad day, worst day ever, 40 nanograms per deciliter. Now this is the day that you don't want to go to work, you don't want to do anything, you want to like call into work and fake vomit on the phone so you don't have to go in, and you sit in the basement and play video games, or you sleep through the day, or you just do nothing. And that's about 40 nanograms per deciliter. Now on the other side, if we have 100 nanograms per deciliter, that's our best day ever. So this is the day that you own an island, win the lottery, and have 2% body fat all at the same time. And our favorite food is like 94 nanograms per deciliter. Sex is about 92. Bummer on that one, but that's just where it sits. This is where we're supposed to live. We're supposed to live between the bad day and the best day. And some days are better than others, and our body just normally moves through the world in that way. Now, some people live a little higher on this scale, and those are the people that, on a Monday morning, they're like, it's freaking Monday, it's awesome. And they can get a little rough to be around sometimes. But then we have the other side, the Eeyores. We're like, well, it's Friday, 2 more days, and it's Monday. And, those are the little lower end of the scale. But either way, we have a natural, scale that we're supposed to be on. And the best day ever should just be your best day ever. It shouldn't get messed up by something on the outside. And so the final common pathway for all addiction is a disturbance of this system. So if my best day is 100 and I, take methamphetamine, all of a sudden my nucleus accumbens, that part of the brain that is feeling and releasing this dopamine, goes from 100 nanograms per deciliter to 1,100 nanograms per deciliter. More than 10 times the amount of dopamine gets released. Heroin in the 900s, alcohol in the 800s, marijuana in the 600s, all addictive substances disproportionately raise dopamine to some degree, and the addictive behaviors do the same thing. And so if we're looking at how we're supposed to live in the world when we have a baseline of 50 and we have our best day ever of 100, and then all of a sudden I'm getting poked around with all of these different drugs or behaviors that's pushing it way up, the body doesn't like that. In fact, the body starts to fight back. And when the body fights back, it has to, manipulate the neuroscience and the neurochemistry of the brain to do so. So if we look at a few different places in the brain, like the periaqueductal gray, this thing labeled PAG, this is where our brain makes endorphins. So you go out for a run, you get a runner's high, it releases endorphins, it goes to this other area called the VTA, the ventral tegmental area, and in that part of the brain it releases dopamine. And then that dopamine goes to the nucleus accumbens, and then that goes to the amygdala and decreases fear, and our frontal lobe is like, I can make good decisions, I can think through things, I can be logical. This is the normal fundamental flow of how life works. Sometimes we have a little more fear and we make, safer decisions. Sometimes we have less and we make bolder decisions. The body modulates that piece based on how the dopamine modulates the fear in the amygdala. Now, there are a lot of other little ways in which it does it, but from a reward system standpoint, if I feel motivated and rewarded, I am going to make decisions that have less fear in them because of my normal dopamine levels. Now, what if we overdo that? What if we go that step further and we add that methamphetamine? If we get methamphetamine in here, now all of a sudden we're cranking up the dopamine signal to the ventral tegmental area. And we're pushing it way out of that 1,100 nanograms per deciliter to the nucleus accumbens. Now we're suppressing pretty much all fear, and now we're not making logical decisions. All of a sudden, it makes sense to jump off of that building with the parachute, even though it's only 4 stories tall. It makes sense to drive the car at 150 miles an hour in traffic. These are the things that happen early in intoxication phases, when you have this massive release of dopamine in the brain and creates this really predictive high-risk behavior. Well, the body knows this isn't okay. So what the body does is it starts to tamp down that signal. And so the first time that you use methamphetamine, you're going to get that 1,100, but the next time, you're going to get like 1,000. or 900 or 800. In fact, you'll never get that same peak dose of dopamine release from that drug ever again. And my patients will call this chasing the dragon. They'll say, well, how in the world did I get that feeling for once and I can't get it again? Well, the body knows it's not okay. So it immediately dials down the amount of dopamine that's produced and won't release it to that level again. If you continue to use that drug or other drugs over time, it's not only going to decrease the amount of dopamine that's released, but it's actually going to decrease the amount produced. When it reduces the amount produced, if that's not enough and those drugs keep squeezing it out, it's going to atrophy the neuron. The nerve that generates and releases dopamine will be shrunk down. And then for opioids and methamphetamine, we have good data to show that ultimately it can kill those neurons long term. And that's like having a stroke in the motivational part of your brain. So over time, if we consistently have that impact of those drugs, we get less dopamine, the size of the neuron decreases, and the neuron can even die. Then we end up with this spindly little looking area in the brain that spits out this little bit of endorphin no matter what we do. Not enough even to give us a normal amount of dopamine from that ventral tegmental area, and definitely not enough dopamine release from the nucleus accumbens. And so our amygdala is free to have fear and anxiety and worry about things, and then we start making decisions based off of that fear and worry, and the frontal lobe can't have a logical decision pathway. So this is where we see people with a substance use disorder start to have really predictable behaviors. When they have fear-driven pathology and this survival mode and craving for that dopamine that we see in them so often. And if we talk about these behaviors, we can think about it as you've injured the brain, we've decreased this dopamine. When you decrease that dopamine, you end up with craving for dopamine. And now that craving may be specific for the drug that used to give you that dopamine. But otherwise, it's craving, and the body knows it needs dopamine, and it knows that this drug does it. So it will crave that drug. And in fact, over time, it will crave that drug to such a degree that someone will go into survival mode. Survival mode is you are working off the id, man. You were working off of the I need it now for survival. Not is it going to upset someone? Is this possibly going to get me in trouble? It is I need this now. And so we see primal actions. And these primal actions can be something simple early. It can be 10 or 20 bucks out of grandma's wallet. It can be pawning something that doesn't belong to you. It can be stealing a couple of shirts so that you can go and get some drugs. At the end, it escalates over time and continues to go up. Now, these behaviors are really predictable. And they're actually so predictable that we've been able to utilize this pattern of behaviors to actually define addiction. And so when we look at things like opioid use disorder, we look at the categories of change that happens in behavior. And if we start with the first one, impaired control, this is where most people will start. They will have, let's just take an example of someone who drinks 2 or 3 times a week. Things got a little stressful. That went up to 4 to 5 times per week. And then on those 4 to 5s, instead of 1 or 2, it's 2 to 4. And then over time they realize, man, I might be drinking more than I should have, and it's been going on for a while. So maybe I should try to decrease that. And they try, but they're not able to successfully do it. They start justifying in their brain, it's just mine. I know what's going on. I can have one more. So you have these unsuccessful efforts to cut back. And then when you can't cut back, then you start to internally justify, like, it doesn't matter what other people think. I'm the one in charge of me. I can do whatever. And then we end up spending more time either making sure we get the substance, going out of our way to go to different liquor stores to pick up bottles so that they don't recognize us coming in weekly for a 5th of vodka, or having hangovers in the morning and having to get up later and show up to work late. And we start craving the substances. Now again, this can be for alcohol, it can be for opioids, but this is the pattern of impaired control that starts at the beginning. Now as that progresses and we have craving, now that craving and survival mode starts to take over. When that starts to take over, we start to have impairment of our day-to-day lives. Now, some of that may be you're failing at your job or your family or a combination of the two. Some of that, may be that you've broken off relationships because people bring it up, or you just don't want to have to hear them nag at you about this over and over again. You may even find that you've given up really important things to you, groups that you used to hang out with, or hikes that you used to go on, or, car clubs that you used to be a part of. Those things just went away because you didn't want to hear it from them, and you didn't feel like they understood you, and you were, basically now starting to become a part of that substance as much as you were a part of that group. And this is where we get into that high risk use phase where you've used it enough to where you're starting to hurt your liver or your heart, or you're using, if you're using opioids, you might be using substances you're not really sure where it came from, and maybe it has fentanyl in it or things like that, but you're willing to take that chance. And then it's causing harm, like you get infections, or you possibly could get HIV or hepatitis C. And at this point, we've now progressed to a full-blown severe opioid use disorder. And it's important to understand that once we've gotten to this point, it is complex to roll that back. Because not only have we, changed our behavior, but we've changed the neurons in our brain that are responsible for that behavior. So we've changed the level of dopamine, we've atrophied some nerves, we've caused the body to try to come up with ways around that atrophy and all of that change. And when we've done that, that doesn't get changed quickly. And so as we start to think about what are our interventions for this, we really have to say, what can we target and help to stabilize this disease process? And one of the things that we've found that is most successful is actually targeting craving. Now, if we could target craving, then we can stop a lot of the processes that occur after that craving and survival mode and primal action circuit that happens, that click-run pathway that we see. So if we talk about craving, a lot of people are like, well, what does that mean? Does it just mean that somebody's sitting around thinking about drug, I need more drug? No. It could be maybe I'm going to wander over by where I used to buy drugs, or maybe I'm going to unconsciously hang out until that guy comes over that I used to buy drugs for, or answer that phone call, or not erase that number off my phone. You can have indirect craving as much as direct craving, but in the end, craving is ultimately defined as a direct or indirect force pulling someone towards a substance or a behavior. And I think that it's interesting because when we look at this, we have parallels to drug craving, and those are things that we also see people get into survival mode for. So one would be water in dehydration, or food in starvation. So when scientists looked at this, they found that if you have somebody who hasn't had anything to drink in 2 to 3 days, and you put them in a functional MRI, which is a magnetic resonance imaging machine that looks at your brain while you're thinking and sees the areas that light up. Now we know the areas that are responsible for craving, and so we're able to watch those and see how intense that signal is. So when they would take that person who's really dehydrated, now think again, 2 to 3 days with no water, and you put them in that functional MRI, you show them pictures of water, you sprinkle water on their feet, you play water sounds in the background, and you look at the part of the brain responsible for craving. What we see is an intensity of craving that is about the relative size of a baseball. And so that's the relative size, not the actual size. And then we looked at food. So people with no food for 3 to 5 days, and then they put them in a functional MRI, and they would bring in their favorite food, and they would like waft in the smell inside of the MRI and have them see pictures of their food, and then even taste it and spit it out, and look at the part of the brain that would light up for craving. And when they did that, they didn't see the relative size of a baseball, they saw the relative size of a basketball. Now, this is important because we know what people will do if they're overtly dehydrated to a point of I'm going to die from dehydration, or if they're in a mode of starvation and they need food. I mean, if I had walked across the desert for 3 days and I got to the end and there's this beautiful glass of water and somebody's like, no, dude, that's mine. You can't have it. I'd be like, all right, throat punch. And then I would grab it and I would drink it, because at the end of the day, I need to survive. And I think If you really think about it, you're put in that situation, you're going to do what you have to survive. And it's no different for food. I mean, we've seen countries go to war over food. We've seen people steal from other people so that they don't starve. And we justify that based on this algorithm of survival. And we know how desperate people will get in those situations. So when we looked at the brain for people who had been off of their substances, specifically opioids and alcohol, for 30 days, 60 days, 90 days, 6 months, 9 months, a year, 18 months. So when we put them in the functional MRI and we looked at their brain, we saw a couple of patterns. So one of those was a significant increase in craving over the first year. It didn't stabilize or go down, it went up. And it went up over time to that first year, not really leveling out until about 18 months. And so instead of, oh, you're off your drug, you should be better, it's not. It just stews and it sits there, and that craving gets more dense and easier to trigger, and it takes a smaller amount of interaction, like a visual cue or the description of where you got your drugs to send that one down the pathway of just lighting way up. And in fact, when I say lighting way up, it wasn't the relative size of a baseball or the relative size of a basketball. It was the relative size of a baseball field. Now, if we look at the realities of what's happening, and we know what people will do in times of craving for dehydration and starvation, you multiply that by 10 and it starts to really explain these what seem like illogical and outlandish and extreme behaviors that we identify in people with a substance use disorder. And that they'll sell themselves, they'll sell their kids, they'll sell their house to get drugs, and that makes no sense unless you recognize that in their mind they are in starvation level times 10. And with that starts to help us predict and understand the escalation of those behaviors to the point at which we see. Now, all that being said, if we take the understanding that we have a high density group of people in jails and prisons and on probation who have this disease, we have good treatments, we know the neurobiology explains a lot of this behavior, now we need to figure out what do we do about it. And I think that we have to understand some basic concepts, and that once somebody meets the criteria for a substance use disorder, their ability to make a decision is just not so simple. It's not a pros and cons list on a refrigerator making a good logical decision. It is in the whole context of survival mode and this overwhelmingly, star bright signal in the brain that takes away the normal, logical, functional thought process. We need to recognize that in society, that medications for opioid use disorder, alcohol use disorder, and tobacco use disorder are just the standard of care, period. And the reason being is it is the only way that we've identified to rapidly tamp down craving and stabilize that dopamine axis. And once we do that, then we can start to do low intensity to high intensity, long-term changes that will allow us to really change the structure of the brain. And if we do that appropriately, we're going to really have this work out well. But if we try to say, well, in 28 days, this should change, that's just crazy. It doesn't make any sense. It's not logical to think that that's going to happen. It took years to get here. It can take years to get out. So being on medications for some patients is a lifelong thing. For some patients, it's a multi-year thing, and then we try to go down. But here in 2022, we don't have data that says that, yes, it's safe to wean people off of medications. All of those studies show that a large portion, typically over 80%, have a significant risk of relapse. And we shouldn't put them at that risk because we don't take people off of their diabetes medication because we hope that their blood sugars will go down because they've been on it long enough. So we really need to be logical about this. And if we start to think about the reality of where we are and where we need to get, less than 10% of the current jails and prisons in our country actually have access to what would be the emerging community standard of care. Less than 10%. That's a big area for improvement. And so we need to really get on that. So for those that have done it, we have some outcomes that are pretty compelling. California prison system, California Department of Corrections Rehabilitation recently published an internal report after expanding medication-assisted treatment across the entirety of their prison system to 16,000 plus inmates. and tracked them for a number of outcomes over a period of years. And they found a few really compelling pieces. One is that they found a 58% decrease in overdose deaths in custody from 2019 to 2020. 58%. That is huge, especially in a large enough cohort, meaning a large enough group of people, to be statistically significant, which this was. And then if we look at the hospitalization rates for things like overdoses and skin infections, those decreased by 18 and 21% respectively. So this is important too. So not only have we decreased death, but we've decreased morbidity, the chances of needing to go for a hospital for treatment. And they also found a significant decrease in the reinfection of hepatitis C and the new infection of HIV. So this is just in one prison system with multiple prisons with thousands of patients. So it's pretty compelling. It's not a single prison in a small place. This is the big time. And so these can be extrapolated into medium and smaller prisons, in the equivalent of 1 yard in San Quentin can be an entire prison in some states. So I think it's important to recognize that at scale, this makes a difference. And if we look at it over a number of different places, we found that after re-entry, we saw a 61% decrease in deaths, which mirrors what we found in custody. And so after this, we had an 82.4% of those people after re-entry who continued care. That is huge. So if we start to really look at the important aspects of this, 1, we can identify them. 2, we can treat them. 3, we have compelling arguments for why this is a positive thing, not only for mortality, but it decreases hospitalizations and thus cost and trauma to those individuals and their families. We know that after we release them, that ultimately their chances are pretty good to have a better outcome than if we did nothing. 61% decrease in death is pretty good, and the fact that 82.4% of those maintain their treatment speaks volumes. So all of this being said, I'd like to just leave you with the basic frame of this is an easy win. This is an easy thing to do the right thing and have good outcomes that are predictable with medications and with interventions that have been around for methadone a half a century, for buprenorphine a quarter century. So as we're looking at these medications for opioid use disorder, it's really compelling and difficult to come up with any argument to say we shouldn't do that, when all of the data, science, and math says we should. Thank you.